Hello and welcome to the Brain Matters podcast, brought to you by the Florey Institute, Australia's largest brain research centre. I'm your host, Dr. Shane Huntington, and together we'll be exploring the fascinating world of brain health. We'll meet leading doctors and researchers and learn about the reality of a range of brain and mental health conditions from people with lived experience and their carers. In this episode, we'll be exploring addiction. Whether we're talking about alcohol or other drugs, gambling, gaming, or even our phones, addiction can be life-changing for people and their families. But is this a human phenomenon? Or is any creature with a brain susceptible? In this episode, we'll explore what is happening biologically in a brain that is addicted and how this could inform future treatments. Joining me today to discuss this important area will be Professor Dan Lubman, an addiction medicine specialist and Executive Clinical Director of Turning Point, Australia's leading national addiction treatment research and education centre. He is also the Director of the Monash Addiction Research Centre and Professor of Addiction Studies and Services at Monash University. Welcome, Dan.
Thanks for having us.
We also have Lisa Rebecca, who has lived experience from alcohol addiction with 12 years sobriety. Lisa is a family therapy trained counsellor and has worked across both public and private health. Welcome, Lisa.
Thank you very much. Welcome to you.
And finally, we have a researcher, Professor Andrew Lawrence. Andrew is the Deputy Director of the Florey and the Head of the Addiction Neuroscience Group at the Florey Institute. Welcome, Andrew.
Thanks, Shane. Good to be here.
Dan, if you don't mind, we'll start with you. As a clinician, how do you define addiction? And I realise there might not be one simple answer to that.
Yeah, thanks, Shane. And first of all, it's great to be here today to talk about this issue, which is one of the most misunderstood conditions. I think there's a lot of myths and misconceptions around addiction and what addiction is. So it's really great to have so many really eminent people in the room to be able to talk about this issue in more depth. So addiction, very simply, is the inability to stop engaging in a behaviour that's causing you harm. And it's largely what underpins addiction is this sense of loss of control, unable to sort of be able to control whether it's your drinking, your drug use, your gambling, your gaming. And essentially that's what we're going to get into today, trying to understand what's happening in the brain, what are the underlying vulnerabilities that affect people so addiction takes hold.
Do we have a feel for what proportion of our society, say, for example, in Australia here, is affected by addiction and what levels that is at?
Yeah, I mean, I think if we think about all health conditions happen on a spectrum. So we have from mild to severe forms of a variety of different health conditions. So around 1 in 4 Australians will struggle with an alcohol, drug or gambling problem at some point in their life. That problem might escalate and develop into an addiction. And around 1 to 10, 1 in 20 Australians will struggle with addiction in some form. So it's pretty common. And I suppose that's why it's really good to talk about it today, because it's something that affects us all. Everyone will know somebody either in their family, either in their workplace, either in their community that is struggling with this issue. But it's something we don't know much about, and it's something we're very confused about. So it's really great to have that conversation today.
Now, Lisa, first of all, thank you for coming in, because this is an area that we don't hear a lot from people who have actually have an addiction themselves or have gotten through it or, are suffering currently. It's been 12 years since you have had any alcohol, is that right?
That's correct. Well, I'm actually 10 days shy of my 12th anniversary. My decision to come into sobriety was, I guess, one that came from a lot of deep pain. My mother died of this disease.
Right.
And I watched and I nursed her over. And I didn't want my children to think about me the way I thought about my mum. Like, I loved her, but she was a woman in pain and I didn't aspire to be like her.
So how old were you at that point when that was happening with your mum?
I was 35.
Okay.
So
yeah.
And my addiction had not yet taken off at that point, interestingly enough. I'd probably had, I guess, run-ins with alcohol and had used and leaned on it and then always pulled myself back. And it wasn't until my late 30s that I recognised that I was leaning more and more onto alcohol to cope with just everyday living and not being able to use any any resilience that I had to do life.
I mean, presumably at that point your resilience was kind of decayed to the point where you really needed a different type of support.
Absolutely. Absolutely. I was exhausted. I had spent so much trying to modify my alcohol use and trying to modify how I did life and my perception of how people saw me that, I reached this point of pure exhaustion and went, actually, enough's enough. I think I'm done,
What did it look like in the sort of scale up? I mean, you said you were interacting with alcohol. I think many of our listeners do, me included, in ways that is, I think alcohol's, we should say, is always bad for your health to some degree. But there was a transition here where you went from, maybe a glass of wine or two a week, which again, always bad for your health, but, not a major concern, to this period where you were starting to question the whole role of alcohol in your life, your personality, everything.
Absolutely. So I went from being somebody who was the total social queen with a glass of wine, loved a cheese platter, invite friends over, to I'll have a glass of wine after I get the kids into bed, to everyday drinking a glass of wine after, and then thinking, I'm hearing these messages that I shouldn't drink every night, to actually slow down and have drink-free nights. What tipped me was those drink-free nights were excruciating. I would sit there and I would know at work that I'm not to go past the bottle shop on my way home. And begrudgingly I wouldn't. I would get home and I wasn't necessarily a pleasant mum, and I would go to bed an hour or so earlier to get the night over.
Right.
When
you did get home on these nights where you were trying to not drink, I mean, what was going on emotionally in your brain at that point? Like, what were you feeling?
So I'd lost the inability to be able to calm myself and de-stress. So I was constantly looking for a way to feel better and shut my mind down. This over-excessive thinking, this obsessional, how many will I have, how many won't I have? Back then, to cut the long story short, I was a theatre nurse and I would have to work out each night of the week according to my roster, which operations I was in, according to how much I could have the night before or not have. It was exhausting, And so I would, on a night that I was not working the next day, what I went to was 2+ bottles a night. And that probably was my extreme. And then if I was celebrating, the 3 bottles would be fine. Of course, I'm not feeling well the next day. And so that's where my drinking got to.
Dan, one of the interesting things here is, I'm not sure if you're hearing what I'm hearing from Lisa, but there's a lack of control. But there's also an incredible level of rational thought and planning. Is this consistent with what you would see with addiction, where not only have we hear about this lack of control and we think, that's the overriding factor, but Lisa's planning this. She's scheduling it around her workplace.
Yeah, I think what Lisa's really clearly talking about is that, that drinking or using drugs or gambling plays a function in people's lives. So, for what I heard Lisa talk about, it was around her mind constantly overthinking things that sort of were distressing or uncomfortable. And to be honest, drugs are great emotional analgesics. They're really great at switching off parts of our brain that cause distress. And I think we're all comfortable. You mentioned, Shane, before that it's common for people to drink. We've all had the experience of having a stressful day, coming home, having a glass of wine, and just that sort of stress leaving us. So I think all of us have those experiences of understanding what the role and functions of these sort of substances can be in terms of how they affect our brain. Yeah. And I suppose what Lisa's saying is when we're talking about addiction, we're talking about something that we all do. But that there's underlying things that there isn't another strategy to deal with, and that alcohol or other drugs are ways of calming the brain, de-stressing the brain, allowing us to function. And even though we know that it can create difficulties for us or creating harms for us, it's really something that's also working for us in terms of helping us get through life.
That's an interesting sort of additional question I have there for you, Liz, was how did you cope with that much alcohol in a given night? I can't imagine personally sort of drinking 2.5 bottles. I think I would be ill. I mean, did you just build up that sort of capacity? How'd that work?
Absolutely, it built up. I certainly didn't start out drinking that amount. And I think, you just adapt to it and you get really used to not feeling great. I was in such denial that most mornings after a night like that, I would make myself do a 10K run.
Right, wow.
And I would feel really unwell. And that just really headed off the denial that I had, because in my mind, I didn't have an addiction. If I could still keep a job, if I could still run 10Ks in the morning, if I could still be the mum that drops the kids off at school, I looked okay. Yeah.
I could see how you would be convincing yourself that,
Absolutely.
I think everyone in the studio, Andrew and Dan were just looking at me like 10K run, that sounds amazing. But, to be able to do that whilst you're, in a sense, punishing your body, in a chemical sense is impressive. Now, you obviously got to a point, though, where even though you just said that you're sort of in denial of this being a problem, you got to a point where you said no.
Yes.
So tell us about that.
It's a very clear moment for me. I had recognised that I'd tried to do a few liver detoxes and stop for a little while and would always use an excuse not to. Then one night I had a particularly difficult conflict with my daughter, then 16, and I was very upset, and I looked into the mirror and I saw my mother looking back at me. And in that moment, I said, how the hell did I become my mother? I didn't like her. So I knew of a friend who had gone to rehab recently, and I made a promise to myself that night that I would ring the next day. And I did. And I rang this particular facility and I said, how do you know if you have an alcohol addiction? And she laughed and said, well, people don't usually ring me.
Right.
And I went, oh, okay. I happened to be living in Queensland. This facility was in Melbourne. I organised to come down to Melbourne. I was going to be down at Christmas for family. So I organised an assessment and I noticed my drinking from that time, which was about 8 weeks until I went down. I noticed what was really going on for me. So when I arrived, I knew, there was no other decision, that my drinking had become very problematic and the issues of my childhood were rising up really quick to meet me.
Yeah. Do you think that knowledge of your mother and what happened with your mother was crucial to you getting out of it? I can imagine a lot of people who are either experiencing this themselves or seeing others experiencing it where there isn't that moment of the person looking back at them in the mirror. That seems to be quite a flashpoint in your history.
Absolutely. Was that pivotal to me? Yes. Do I believe that for others it can be helpful? Absolutely. I think if we are able to meet with people earlier to understand their earlier experiences and how that can be impacting them, I think prevention's better than treatment.
Yeah, absolutely. And a big part of your working life is helping people who are in essentially the same situation you're in, and you're working as essentially psychological support for those people. Tell us about what you're doing now.
So now I am a counsellor. I've specialised in alcohol and other drugs, and I'm also family therapy trained. So I work with a lot of families who are just trying to understand this disease. I can't tell you how many families say to me, can I just love them enough? What can I do? And I often say them loving you has nothing to do with their addiction. They can still love you with all of their hearts, and their behaviour shows you the opposite. Yep. And so it's about educating families, supporting them, hearing what they're going through so that you can give them some hope.
Yeah. Now, you just mentioned educating families. I think it's interesting. You are in a prime position to comment on this, but the stigma associated, especially with alcohol, in addition to other addictions as well, but in particular with alcohol, is very, very strong. You've seen that now from both sides. Is it changing at all? How much of an influence did that have on you?
Is it changing? I'm really not sure. I'd like to believe it is. Is there the stigma for families? I can't tell you how many families I sit with who say, you're the first person I've told my story to. I don't tell the other mothers at the school. I don't tell other people at work what's going on for me at home. You know, I'm really the first person that they can share this story without feeling as though they're at blame or they're at fault. And I tell them, you know, regardless of your earlier experiences as a family, you are not responsible for somebody else's addiction.
When you think about alcohol now, and you talk to people in general, so not people who have addiction, society seems to have this, you know, let's chill out and go and have a drink, or let's, you know, these are the things we do. I mean, how do you see that now, given what's happened to you, given the potential danger, not for everyone, but certainly for a significant group of people? How do you see that societal push? And part of it's marketing, part of it's money, part of it's just the way we communicate, especially in Australia. How do you see that?
This is something I'm incredibly passionate about. I think as a society we've forgotten to have fun, how to be without using drugs and alcohol to modify what people see of us. Every message is let's celebrate and have a drink, or let's commiserate and have a drink. You know, I've been really blessed to be a part of the marriage of 4 of my adult children, and I haven't had a drink at any one of their weddings. And I have had just as much fun as everyone else at that wedding. And people say to me, aren't you bored when you go out? And I'm going, well, you know, I have faith in who I am as a person, that I can have fun without using a substance to modify who I am.
Yeah. I find it incredible you've managed this for 12 years. I know as someone who MCs a lot of events and so forth, every 5 minutes afterwards someone's handing me a bottle of wine as a thank you. The societal pressure there and your actual, you know, disease put together is the worst possible thing you can have. So, I mean, do you find after 12 years it is getting any easier, or, you know, is it still always right there in the back of your mind?
For me, no, it's not in the back of my mind to have a drink at all. In fact, I never think about it. Those that are concerned about, you know, maybe their own drinking or others around them will always be worried about me at events and say, well, how are you going? Are you doing okay? And I'm like, yeah, I'm great. You know, most of my kids put a mocktail on the actual menu at the weddings, which was lovely for them, but I was fine if they didn't. But yes, there is an incredible pressure when anybody is out that if I'm not drinking, they're concerned. And I'm like, I'm actually the best person in the room right now because I can see and feel and hear everything.
Yeah, interesting. Dan, in your practice, you see all sorts of addiction, I assume, in various forms. Why are some of us seemingly more susceptible than others, or is that a myth?
I mean, I think there's a whole range of reasons why people are at risk. You know, just coming back to what we talked about before, I mean, these drugs that we're talking about, and alcohol is a drug and our most common drug, and the drug that we see, you know, the most common drug that people present to treatment for is for alcohol. And, you know, just, you know, listening to Lisa, I mean, I think the surprising thing and the really important thing about having this conversation today is that we don't talk about it enough. You know, it's something that can do us an enormous harm, as you've already said. It's associated with so many problems, so many physical, mental health, social problems, but we don't actually have a conversation about it. In fact, the only information we get about it is from adverts we see on the telly telling us, why not have a drink? It's, it's time to get your hair done, time to go to the cinema, time to go and watch your kids' sport, let's have a drink. And there isn't any government messages that actually tell us that, first of all, that people can get into trouble with alcohol, or there's no messages that tell us that actually there's treatment available. And so, as Lisa has said, it's not surprising then that, we have this astonishing figure that it takes a median of 18 years from when somebody develops a problem with alcohol to seek treatment. So we have this huge delay in help seeking for a health condition. And if it was any other health condition, we were talking about cancer, heart disease, depression, we'd be aghast to be on the front page of the newspaper, but there's silence when we talk about this issue. And I think that's why it's really important we talk about it.
So, you talk about other issues. A good example of this is endometriosis for women or anyone with a uterus, and the time frame there is usually 7 to 10 years. Because of the way the healthcare system operates around women, is this condition, that you talk about 18 years, is it worse for women?
Absolutely. Yeah. Absolutely. And Lisa will probably comment on this, but, addiction is the most stigmatized health condition. It's something we don't want to talk about. It's something that we don't think is a health condition. We see it as some sort of moral issue that people are just making bad choices. Why don't they just make the right choice? So, we're not talking about it. There's a huge amount of stigma. You've already talked about stigma in the family. So families feel to blame. Families don't struggle to reach out for support themselves because they feel like they're going to be judged. And for women, as you know, there's already additional stigma around women's health issues. And when you combine addiction and women's health issues, what you have is that double stigma. So certainly what we see in treatment, we see less women coming forward for treatment, not because women aren't affected, it's because there's more judgment and shame associated with addiction, and so they're much more unlikely to put their hands up. So hearing Lisa's stories is really important because it's a story we hear all the time, and getting people to understand that this is incredibly common. It's a really common issue. And there's amazing treatment options out there and great science that's sort of leading us to sort of new ways of addressing this issue. It really is a story of hope, and we just need to get the message out there.
Let's talk about the treatment options specifically. So someone like Lisa turns up to your clinic, whether they've been, self-evaluated, sent there by their GP, family member, however they get there. What does that look like once you have them in the room? They're addicted to alcohol. What's the process, and what can you do for them?
Yeah, I suppose the first time we're meeting people, there's a number of things we're taking into mind. One is understanding sort of the level of drinking or drug use, and understanding what it is, understanding that impact, and understanding how, what are the options in the short term and around reducing sort of the harms associated with that and keeping people safe. The second issue that we're always dealing with is trying to understand the functional significance of why they're using in the first place. So people are choosing to do this because there is a functional benefit to drinking or drug use, and as Lisa said, there's, that might be underlying trauma, that might be undiagnosed anxiety or depression, underlying ADHD or other sort of mental health issues. It could be huge stresses in the family. It could be a whole range of things. So trying to understand the functional significance of why people are using and why it's so hard to stop. If we don't address that underlying issue and give people better coping strategies to deal with that issue and work through those issues, then it's going to be almost impossible to get people to stop, because that's the only thing that's working for them.
We hear a lot about various addictions. We talk about cigarettes, we talk about alcohol, we talk about a broader range of drugs, some of which are, becoming legalized, some of which aren't. There's a lot of criminal aspects to that are problematic as well. In terms of the sort of addiction capabilities, in terms of dealing with addiction that you have in the clinic, though, where does alcohol sit? We hear about cigarettes and how hard it is for people to quit from that. It's a very strong biochemical addiction. Yeah. What is it like for alcohol?
Well, I think if we look at the history of cigarettes, we know, I still look back at my childhood and think about sitting on planes where I was sitting in a non-smoking section and the rest of the plane's full of smoke. And it's crazy when you look back at some of the ways we used to deal with these issues. And what's been really clear that since we've come, essentially the public has understood the harms associated with tobacco, there's been a huge public campaign, there's been a huge shift in our thinking about tobacco. And the majority of the population have decided that they want to smoke and have cut. And so the smoking rates in Australia now are down to 10%. And what that says is when we have these honest conversations, when we help people to understand the harms, when we give people the tools and skills to be able to quit, people can. And the challenge we have in this space is, as Lisa says, is that because we don't talk about this and because alcohol is everywhere, and essentially, I don't know how Lisa does it, because everywhere you go, people, the first thing they do is offer you a drink. And then if you don't want to take a drink, they want to know why you don't want to take a drink. So it's this constant interrogation and pressure to sort of be part of that sort of social ritual. So, because of that, the relapse rates and sort of the difficulty in quitting related to alcohol is one of the hardest. It's actually harder to quit alcohol than it is other drugs because you're in a social environment where there's adverts for it everywhere, it's being promoted everywhere, and everyone is encouraging you to drink. Whereas if you decide to give up drugs, it's very much easier to separate yourself from other people you might have been using with and sort of not have that in your life. But with alcohol, it's all around, and that makes it very, very challenging.
Professor Andrew Lawrence, sitting over here as a researcher, you're in the lab, you're probably working on all sorts of animal models and so forth in this space. I mean, when I hear about this, one of my questions immediately is Lisa's brain different to mine? Is it operating different? Has it changed as a result of the addiction? What do we know about the human brain and what addiction does?
Yeah, so I would say some years ago it would have been different to yours, but now it's probably very similar to yours based on what Lisa said. And I think it's complicated, and we research we do a lot of research in animal models, we absolutely do, but we also research actually human postmortem brains. There's a brain bank in Sydney, the New South Wales Tissue Resource Centre, and part of that brain bank is a collection of brains for people that have died with alcohol use disorder and very graciously donated their brains for research for us to exactly do that, to see what's happening inside the brains. And we've done that, and we started out, we took a part of the human brain that we knew was a key part in terms of that anticipation and preoccupation that we heard about, and looked at what was going on in that part of the brain and identified some molecules that we've seen were changed in the alcohol brains relative to the non-alcohol brains. And then we back translated that into rats and mice, and we found exactly the same changes. And then obviously in the rats and mice, we had the ability to intervene with new compounds that target the molecule that we'd seen had changed. And we saw that at the behavioural level, they could reverse the animal's desire to consume alcohol, and they could prevent the animals relapsing back to seeking alcohol after they'd been through a version of rehab. So we can do that, and that's basically what we're trying to do, is to identify new therapeutic approaches that can assist people stabilising, reducing that craving, reducing that preoccupation and the desire to consume, and therefore engage in other strategies that are long-term behavioural strategies to help solve the problem.
So that's very interesting to me. I've got a few follow-up questions there, obviously, because there's some detail there. Those molecules you were looking at in the brain, are they the result of sort of the alcohol damage and the way the brain is sort of trying to function when it's got so much alcohol hitting it? Or are they a reaction from the brain to seeking, more alcohol? Where in that process are these molecules that you're talking about that you can eliminate? Yeah, so it's a very good question, because when you look at a snapshot in a postmortem brain, you don't know if it predated the problem or was a consequence of the consumption. But that's the beauty of going back into the animal models, and we can confirm in both rats and mice that the issue was caused by the alcohol use. It wasn't predating the alcohol use. It didn't signify susceptibility to alcohol use. It was definitely a consequence of the long-term alcohol use. And in fact, we found that long-term use plus abstinence, or the intermittent long-term use, was the worst, actually. Oh, really?
It caused much bigger problems in the brain, both particularly in rats and mice. And we're looking now using a technique called PET imaging, and people are often familiar with having PET imaging for diagnostics in humans, that we're using that same technique in animals to look in the same animal throughout time to study the trajectory of the changes in those molecules as a consequence of the alcohol use, and then what happens when we put the animals into abstinence and look at the trajectory of the recovery of the expression of those molecules so we can track it out.
So PET being positron emission topography imaging, what is different in the use of that to, for example, functional MRI imaging or any of the other dynamic imaging modes? What do you get out of the PET imaging that's specific?
With PET, we can have a radio-labelled molecule that directly binds to our target in the brain. And we'll look at that and will tell us not only where it is in the brain, because we know where it is in the brain, but it'll tell us how much of it's there in the brain. Whereas fMRI or structural MRI won't do that. And of course, it's very hard to do functional MRI in rats and mice because it's very hard to keep them still for any length of time.
With regards to these molecules, so you identify these and then they're presumably therapeutic targets, a way in which to deal with the addiction. What would that look like in terms of a patient? So would you get them sort of midway through the addictive process? So like, they're obviously, as I think Lisa was, she's recognizing there's a problem. Would that be a sort of chemical treatment that you would give to remove the desire, or what exactly would that therapy look like?
Yeah, I mean, that's a great question, and that's exactly what we would do. We would start to treat the patients either immediately when they go into detox, or once they've been through detox and they're about to go back into the community and start a structured program of treatment to reduce craving, to reduce that the anticipation and the preoccupation with the desire to consume alcohol, and help them stabilise that behaviour so that they can then engage in other strategies such as cognitive behavioural strategies or coping strategies or workshop groups or things like that. So we've done that with one compound already, where we did a proof of concept trial where we took a young man, in fact, mid-30s, drinking 2 bottles of wine a day, and we put him on a treatment medication that's not registered for alcohol use disorder. It's registered for insomnia. And 13 weeks later, that individual had been 100% abstinent, hadn't consumed a drink for 13 weeks. Their liver function was much better than it was. Their anxiety levels had reduced, and they no longer had insomnia, so they were sleeping properly. So we can demonstrate at a proof of concept level that we can use preclinical research from a mechanistic perspective to drive new treatment programs. That obviously that's an example, that's a case report. It needs to be reproduced and replicated at a broader scale. In fact, Dan and I are in a program of a team of researchers that are going to commence on a second trial in that strategy. And then obviously once we get it expanded, if it continues to be successful in a broader group of people, then that's another option.
I mean, I think one of the really important things here about investing in brain science is that we're still trying to understand parts of the brain that alcohol is actually affecting that lead to the addictive process. So, I think over the last 50 years, we've learned much more about the brain and different brain circuitries and different parts, the functions of how those parts of the brain work. And so what's really exciting now as we learn more, it gives us much more opportunities to look at different compounds that can affect different parts of the process. And that means the really good message, I think, for people out there is that there is growing number of effective treatments out there, really effective treatments that people can try. It's great to have options. The challenging thing, I think, because of stigma as well, is that despite having a number of different pharmacotherapies, medications on the market in terms of being able to effectively treat addiction to alcohol, only 3% of people who are eligible to have those medications actually receive them in this country. And that's largely because of stigma, because people aren't aware of it, because even within the health system, a lot of our colleagues have not been trained or have not been supported to understand the breadth of different treatment options that are available. So it's really exciting, but there's a lot of work for us to do in terms of upskilling people's knowledge, upskilling the public, letting people know that treatments work, hearing stories like Lisa, hearing those stories of hope, and encouraging people to put their hand up for help.
I always equate it to if you had high blood pressure, you go to the doctors and say, "Hey, doc, I've got high blood pressure, can you help me?" And there's a whole raft of different medications that have completely different mechanisms of action, but they all have the same net effect of bringing your blood pressure down. One of them might work for you, it doesn't work for me, and vice versa. But the bottom line is, whichever one we go with, we end up with the same net effect. So it doesn't matter how you get there in terms of a mechanism, it's getting there. And I think that's the message I'd like to give from an addiction treatment perspective, is that at the moment, the toolbox is limited, and we're trying to expand the toolbox because we know that the drugs that are currently available will work very well for some people, but not for others, just in the same way a particular drug that reduces blood pressure will work for one person but not another. And therefore, we need more options so that we've got a bigger toolbox so that we can basically try and use a precision medicine approach where we treat people with the most appropriate medication for them, for the way they respond to it and so on. And I think that's really important. I think psychiatry in general has been lagging behind other forms of medicine, but I think we are slowly getting there.
When we see responses to things like cancer, I mean, that is a great example where comprehensive care models and precision medicine, in particular around genomics, has just, really changed the landscape. How far away are we, like Dan, in your clinic space? I mean, would it feel anything like going to one of the big cancer centres, or are we still so far sort of behind that managed care sort of mindset that we struggle to achieve what Andrew's talking about?
When I think about when I trained in medicine and I think about cancer at that time, people had no hope around cancer. People thought it was a death sentence. And because of that, people didn't believe treatment worked. So people delayed treatment. We used to see people come in with tertiary sort of end-stage cancer. People didn't come in early. And because of people telling stories of recovery, because of the community getting behind that, it wasn't good enough not to have those approaches, there's been a huge investment in cancer treatment. And what we've seen that's translated into, as Andy has said, is a whole breadth of different treatment options, saying it's not good enough just to have what we have available. We need to invest in more. We need to have more research. We need to develop more treatments. And we've seen a complete sort of reversal in how we think about and approach cancer. And there's a lot of hope there in the community, and everyone is behind an early intervention response. And I think there's no reason why this couldn't be true in this area as well. And I think having conversations like we're having today to really elevate the discussion are critically important in saying this is a really common issue. There's great treatments out there, but we can do a lot better. And we all, as a community, need to raise this issue and say, as we said right at the beginning, everyone knows somebody in their social circle who's struggling. We should have the same range of options available, like for blood pressure, like for cancer. That's something we need to be striving for.
Lisa, it's interesting talking about cancer because there is one type of cancer that still has a very strong stigma attached to it, which is lung cancer. And often the societal mindset is still it's your fault. You must have felt this stigma with regards to your disease, and this is something that we have to change. What would you do, and how do you see the healthcare space? Does it help with that? Is it part of the problem? What would you like to see change?
Yeah, absolutely. I believe that our whole perception around seeking treatment, it needs to be an ongoing conversation all of the time. For me, I guess what allowed me to shift was my perception around what alcohol gives us. If we could share with the wider community, what does alcohol give you that you can't give yourself, would be another way to really broaden the conversation and also normalise the fact that if there is a concern, that there is some treatment options out there for you. It is the stigma that we need to really combat. But also we need to combat what people think they're getting from alcohol. For me today, it's liquid in a glass. It doesn't hold any part of me, but for many people, it holds everything. It holds their ability to get through a day. It holds the nightmares back. It holds their friendship groups, their peers. I'm very blessed today. I have a huge network of people that I'm truly connected with that I've never had a drop of alcohol with. And so not many people have this understanding of what the world can look like. We see it very narrowly through, you know, what society tells us about how we can be, rather than allowing us to grow into who we are without anything else.
Does your friendship group know your backstory there? So they fully accept that?
Yes.
Yeah.
You know why? Because I'm really proud of it. I don't hide from it. It's the stigma that keeps us in secret. You see, when we can break the secrecy of this and be really open and honest, obviously I have a few people now who will always say, do you think I have a problem? Because I am approachable about it.
It's your job. It's your job to be that, yeah.
Absolutely. I think we need to bust the secrecy around it as well as the stigma. You know, if we can normalise this and say, hey, we are going in leaps and bounds with treatment options, just to have an addiction doesn't mean, you know, you have to navigate down this particular path. Like, have the conversations. There are so many opportunities for information and new research coming out that we just don't talk about, and we need to.
Yeah. Andrew, one of the questions I like to finish these podcasts with is around funding. And if we were to give researchers or clinicians a big bucket of cash, you know, a lot of money, what would you do next? And I think I partly know the answer because you described how there was such a range of blood pressure medications and that we don't currently have that for certain levels of addiction. Is that the direction you would head in expanding, or is there something else that's crucial for you at the moment?
No, I think absolutely. We, as Dan alluded to earlier, the funding for addiction research relative to, say, cancer research is chalk and cheese. And yet, if you look at it just from an alcohol perspective, there's over 400 million people in the world, at WHO stats, that have got an alcohol use disorder. 400 million people. So it's a very common problem. And that's just alcohol, nothing else. And so what we really need to do is expand our toolbox. At the moment, there are 3 drugs that are approved by the FDA for alcohol use disorder, only 3. There are other drugs that are used off-label, as Dan alluded to, but we know that there's a whole range of other potential options that we've discovered and other colleagues around the world have discovered, but we need the investment to be able to really work through those and validate or not those and get small molecules in new medications designed and synthesized that can interact with those factors that we've identified, that can then ultimately, once we've been through all the safety, can be empirically tested in humans. And that takes a long time and it takes a lot of money, but there are opportunities. The other thing that we should be wary of as well, or open to, is repurposing medications that are licensed for something else. And a good example is Ozempic. Everybody's heard of Ozempic for type 2 diabetes and a lot of people using it for weight loss. Well, there's currently a trial underway looking at Ozempic as an option for alcohol use disorder.
Wow.
So that's a really important way as well, is not only looking at new molecules and new chemicals as new medications, but also looking at, based on what we know, how alcohol interacts with the body and interferes body functioning and brain functioning, systems that have medications already available that might be of value.
And this is what you mean by off-label medications. So,
that's right.
So they've gone through all the safety and the approvals. They're sold for various conditions, but we're talking about using them for a condition that they weren't originally purposed for.
That's correct. So they might be registered to treat diabetes, for example, in the case of Ozempic, but it might still have utility for some people in the treatment of their alcohol use disorder.
Dan, similar question for yourself. You know, a big suitcase of cash turns up at your clinic, not for new cars, but to do something really transformational. What would that look like in the sort of clinical space? I mean, you obviously have a strong research bent to your life as well, but where would you invest that? What would that look like?
That's a really tough question because there is a lot to do in this space. But that's why I suppose all of us are in here. We're very passionate about this issue. It's such a common issue. There's so much that can be done and it doesn't have to cost a fortune. I think one of the key things for me is this 18-year delay in help seeking. You know, we've got to work out in any other part of healthcare, early intervention is the norm. I think Lisa's already alluded to this. Getting people to recognise the issue area, putting their hands up for help that sort of reduces enormous costs on the healthcare system. So we've got to find ways of getting people to reach out earlier. And that's around promoting the issue, talking about the issue, letting people know that help occurs. And, I suppose piggybacking exactly what Andy said, it's about how do we ensure these medications are best utilised in healthcare systems, making sure that not only do we have access to them, but people have can put their hand up and be offered it when they need it. So we need to really educate our healthcare workforce. We need to encourage people to put their hand up for help early. We need to address the stigma that Lisa's talked about, give people confidence and hope, and create a system where, like any other part of the healthcare system, when you put up your hand for help and you say, look, I've got myself or my family member, I've got this issue, you expect to get gold-class treatment because, we're very fortunate in Australia. We have a really fantastic healthcare system. If you put your hand up for a whole range of health conditions, you get the best. And that should also be the case when we're talking about alcohol and other drugs.
It's a great place to end. Professor Dan Lubman, thanks so much for chatting to us.
Thanks so much for inviting us.
And Professor Andrew Lawrence, good luck with the ongoing research in the lab there. I think, ultimately a lot of this in the future, not today's therapies, but in the future it's going to come down to whether or not you can isolate some of these pathways and really work out how to either switch them off or modify them.
Yeah, thank you. I mean, we are doing that. And one thing I'd just like to finish on is that there's a drug recently been approved to treat schizophrenia, and we think that may also be a really good option to test for alcohol use disorder. And in fact, I'm in contact with the drug company that have produced that compound to see if we can access it, to test it in that way, because we know it's safe. We know it's been in humans for more than 12 months to treat schizophrenia. And it's the molecule I said we were tracking with the PET scanner. It's that drug interacts with that target. So it would be a lovely thing for us to test and find out one way or the other.
Lisa, Rebecca, thank you so much for telling us your story. It's an inspirational one. It shows that there is a path out of this, and you've certainly been walking that path successfully now for over a decade. And what I'm hearing is that that's not going to change.
Absolutely not going to change. And thank you so much for having me today.
You've been listening to the Brain Matters podcast, brought to you by the Florey Institute of Neuroscience and Mental Health. Join us for our next episode on brain health, and if you have a particular topic you would like us to cover in the future, please drop us a comment or send a message via the email in the show notes. I'm Dr. Shane Huntington. Thank you for listening.